Thank you very much, Professor Bukusi, for this really great introduction. And thank you to the organizers for the opportunity to speak about menopause and whether it poses challenges or opportunities. And I want to declare that I feel very humbled to be asked to talk to you about this, because I don't practice in Africa. And I'm sure that there are people who could speak to this much more eloquently than I. But I would say that my background is as an HIV and sexual health physician in London. And I run a general HIV clinic, but I also run a clinic for menopausal women living with HIV, the majority of whom are African or of African origin. So I think that there is perhaps a little bit of legitimacy to my being asked to speak to you today. So aside from my job in clinical work at a large London hospital, I'm also a part-time employee of ViiV Healthcare. So we all know that global life expectancy is increasing. And by 2025, the WHO estimates that the older population in sub-Saharan Africa will have doubled from 2010. But also, and really importantly, by the late 2020s, 76% of menopausal women will be living in developing countries, including Kenya. And this slide, although it's a graph now that is fairly old, it is still relevant, and it shows the number of women accessing HIV care in the United Kingdom by age group. And you can see, I hope, that the age group of 45 to 56, which is the menopausal age group, represents a third of all the women living with HIV. So there are 100,000 people living with HIV in the UK, and 30,000 of these are women, and a third are women of the menopausal age group. And Public Health England, who produced this slide, no longer called Public Health England, estimates that in the next 10 years there will be a further 10,000 women entering this age group. And although these numbers and potential proportions will be different in different countries, the trends will absolutely be the same. And so this is an age group that we really need to think about, both from the point of view of just being menopausal, but specifically from the point of view of being menopausal and living with HIV. And I'm going to talk to you about some of the intersectionalities and opportunities, actually, for managing women living with HIV who are in menopause. So just by way of background, for people who may not know, the definition of menopause is the last menstrual period, the final period. And it's a retrospective diagnosis, if you want to sort of talk about it in terms of a medical condition, which arguably it may be considered to be. So menopause is said to have occurred 12 months after the last period. And obviously, at the time of the last period, a woman isn't aware of the fact that that's her last period. And it's usually a gradual process, but it may be sudden. And we will be talking to Patricia, who very kindly is here to share her experiences with us, because she had menopause following surgery. And so we'll be talking to her about how this happened and what her experiences were. The menopause is a transition, and so I'm showing you this slide very quickly because there is relevance to the fact that it's divided into stages. In the premenopause, women are protected against osteoporosis, cardiovascular disease, Alzheimer's disease, and insulin resistance, so the precursor to diabetes, by estrogen. And during the perimenopause, women start to have symptoms but may still be having periods, and so may not recognize this. And symptoms may start early. They may start in the early 40s, they may even start in the 30s and may last for a long time. And then at the time of menopause, periods stop. The postmenopause is important because we've talked a lot about comorbidities at this meeting, and the postmenopause is the time at which women enter a period where they are at risk of long-term comorbidities, which I'll talk to you about in a moment. Surgical menopause refers to the removal of the ovaries for various reasons, and the difference between surgical and natural menopause is that menopause starts immediately, and there are implications for this which we'll talk about in our conversation with Patricia. So, although the majority of people think about menopause as hot flushes and sweats, over 30 symptoms of menopause have been described, and 85% of women in menopause will experience symptoms of some kind, 25% severely. And the symptoms that I've highlighted in bold are the ones that have the most profound impact on quality of life and on ability to work effectively. And so, although I'm not going to go through all of these because we don't have enough time, I think it's important that people are aware of the fact that the symptoms of menopause are multifold. And then there's this, and I'm not going to go into this at all, but it's an aspect of menopause that hardly anybody speaks about, but is a big problem and the contributor to a lot of sort of ill health in relationships. And I think it's really important that women are able to speak about this. And again, I'm going to speak to Patricia about her experiences. So what is the impact of HIV on menopause? So unfortunately, there are very few data, and this is an area of sort of a lack of data generally, menopause. Nobody is interested in studying older women globally, whether you're living with HIV or not. And it's only now that research is starting to be published about menopause. But with HIV and menopause, there are even fewer data. Most data come from the United States. We're starting to collect global data. And in fact, many countries in Africa are now collecting data and doing research in menopause, particularly in menopause and HIV. There are data that show that menopause may occur earlier in women with HIV, that women with HIV may experience more severe menopause symptoms, including data from Zimbabwe. And the diagnosis of menopause is often delayed because women think that their symptoms are related to their HIV, and it's not until sometimes years later that they realize that their symptoms are due to the menopause. There doesn't seem to be any evidence that estrogen depletion, so the reductions in estrogen that happen because of menopause, impact sort of progression of HIV. But we know from a study done in London, which my colleague Annemiek de Ruyter's hospital contributed to, that women with severe menopausal symptoms may not take their antiretroviral therapy properly. And we heard this yesterday with regard to women with mental health problems. And there's a potential additive effect of HIV and menopause and comorbidities that we really need to understand. And so, but what we do know is that women living with HIV and women in general are unprepared or underprepared for the menopause, particularly if it's surgically induced. They are often unable to discuss it. They are often isolated, particularly if they're women who migrate from their homeland to another place and don't have any support. And they often attribute, as I said, their symptoms to HIV or their antiretroviral therapy. And they're made to go back and forth between primary care and the HIV service before somebody helps them to find out what's going on. And many of the morbidities that we know are associated with HIV are increased even in people who are treated for HIV. And the conditions that I've highlighted are particularly important in menopause, and menopause makes them worse. We saw what happens to the bones as women get older, as people get older, and menopause increases the risk of osteoporosis significantly. Women lose 10 to 20% of their bone loss as they go through the 10 years in the first 10 years of menopause. Cardiovascular disease I'll speak about in a moment, and we heard about cognitive decline and frailty yesterday, and these are really important in menopausal women. So why does menopause matter? So people don't think about this, but heart disease is the biggest killer, the leading cause of death in women. 50% of all deaths in women globally are because of heart disease. And as I said earlier, estrogen protects women from heart disease, but after menopause, cardiovascular disease rates go up to be as high as in men and higher. Cardiovascular disease and osteoporosis we know are more prevalent in women with HIV, both because of their HIV, but also because of certain antiretroviral treatments. And menopause, as I said, increases this risk. And menopause has a significant effect on women themselves, on society, the workplace, the family, and relationships. And it's something that for years and years has been swept under the carpet, but now people are starting to talk about it. And it's really important that people do talk about it. The other big impact of menopause, particularly for women living with HIV, is depression. So we know that people living with HIV have a high burden of mental ill health, anxiety, depression, mainly, and menopause increases the risk of these. And I'm not going to go through all of these because I only have 5 minutes, and I have Professor Strict beside me, but you can see what's on this slide, and I would be happy to share this presentation after the conference if people want to see, to read some more. So what can be done? So thinking about this from a clinical point of view, I think the first thing to do is to identify it. So in my experience, women will generally not volunteer that they have menopause symptoms, but if you ask them, they will tell you. And so it's really important to ask. So asking about menopause symptoms in women over the age of 45, but about menstrual cycles in all women so that you can identify women who are experiencing early menopause. Discuss hormone replacement therapy, and I haven't talked about hormone replacement therapy at all in this talk because I know that it's not readily available everywhere, but it's important to remember that menopause is a hormone deficiency state, and the way to correct a lot of the manifestations of menopause is to replace the estrogen that's no longer being produced. But even if you don't have access to HRT, there are other measures that will serve to improve quality of life and also hopefully longevity. Lifestyle is really important, and I'll mention this a little bit more in the next couple of slides. Really important to have open conversations about medicine, about menopause across society. So we've heard that in the school curriculum now in the UK, they're going to introduce the issue of menopause early, and particularly talk about it with boys, because it's really important that men understand what the impact of menopause is. If you do not specialize in menopause yourself, establishing referral pathways that work so that women can be seen by people who have experience in managing menopause. And also consider training in menopause, which is what I did when I found that there was nobody around that I could refer my patients to. So although I'm not talking about HRT, sexual dysfunction, genital symptoms are really important and very, very common and last for many, many years. So finding topical treatments that work, and vaginal estrogen, which is easier to obtain than systemic HRT, for example, and has very few adverse effects, are really, really helpful in improving the quality of women's life, not just in their sex life, but just their general life. Dietary and lifestyle advice are really important. Nutrition is crucial. Thinking about a diet that is very, very, is high in fiber, in highly colored fruits and vegetables to provide antioxidants, physical activity, but the right kind of physical activity. One of the things that happens in menopause is estrogen loss causes bone and muscle loss. So it's really important to do activities that increase your strength. So strength training, weight training. That doesn't mean going lifting heavy weights in the gym, but things that carrying shopping, that is weight training. Walking, running if you want to. Things that increase your cardiovascular health, but also your muscle strength and your bone strength, and that will prevent you from falling. Good sleep. Reducing alcohol if you can, particularly if alcohol increases your symptoms. So for some women, alcohol doesn't have an impact on symptoms, but for many, it makes it worse. So thinking about trying to reduce the amount of alcohol that you drink, and profoundly importantly, stopping smoking. And so this talk was entitled Management Challenge or Opportunity. So for me, I see the opportunities as being able to normalize conversations about menopause and change the narrative, which is basically that once a woman becomes menopause, she's of no use to society anymore. That is patently untrue, as many of the older women that we see in this room attest to. Raising awareness of the impact of menopause on women and society in general, providing formal and informal support. So support networks are really important. We've talked about peer support for women who are breastfeeding. Peer support generally for people living with HIV and for people in society are important. Doing data, getting data, studying women and understanding in your own context what the situation is. Challenges, stigma and shame are widespread. Attitudes of women towards menopause are bad. Oh, you just need to put up with it. And HRT is not necessarily accessible even when people want it. Lack of menopause research, as I said, and a general lack of menopause expertise, which is the reason that a lot of people who might need support can't access it. Remember that 40% of a woman's life will be spent post-menopause. Women should expect healthy lives, not just long lives. We wrote this booklet, a guide to menopause for women living with HIV. The link to it is on this page, so if you'd like to have a look, please do so. There are translations in lots of different languages, which I can send you links to later. And these are a few references, including a reference to a book on menopause that was referred to yesterday by the South African Menopause Society. So here we are. That's my last slide, and I'd like to say thank you very much. And I was 16 seconds over time. I apologize.